So once again, pathology of the orbit is the lecture today as a part of the series on the ophthalmic pathology course. And orbital inflammation is classified into acute and chronic, just like the inflammation elsewhere in the whole of the human body. Acute inflammation is either non-suppurative or suppurative, and chronic inflammation is either non-granulomatous or granulomatous. And non-suppurative inflammation is presented in the orbit by orbital cellulitis, and the suppurative type is presented by purulent infections and mucormycosis. And chronic inflammation, non-granulomatous type, is represented by the Igg4 disease, which was previously known as the chronic orbital inflammatory disease or orbital inflammatory disease or orbital pseudotumor, now known to the literature as the Igg4 disease, and we'll see how later on. Granulomatous includes sarcoidosis, tuberculosis, fungi, and Crohn's disease. We shall start by orbital cellulitis, and this is an active infection of the orbital soft tissue posterior to the septum. If it's anterior to the septum, we call it preseptal cellulitis. And actually, this is not a frank orbital cellulitis, it's rather an inflammation in the lid. The commonest cause of proptosis in children is orbital cellulitis. So remember always that the commonest cause of proptosis in children is orbital cellulitis. It is not tumors, because tumors in general are rare. It's usually secondary to spread from the sinuses through the medial wall or recent trauma. And if the orbital apex is involved, vision, pupil, and ocular motility will be involved. There is a very important point here, is that below 1 year of age in children, the maxillary sinus is a patent space, but almost non-existent. That means that the teeth in the upper jaw are in very close proximity to the orbit. So trauma in the teeth might easily lead to orbital cellulitis. And this is here an example of orbital cellulitis. Now we come to the second suppurative acute inflammation in the orbit, which is mucormycosis, and this has recently come to attention as a complication of COVID-19 syndrome in patients chronically treated by steroids and the monoclonal antibodies. The fungi causing the mucormycosis issue are the family Mucoralis from the genera Mucor and Rhizopus, and these are commensals. Actually, these are commensals in the human nose. The disease is rare and serious, but now it has become not rare at all. I wouldn't say common, but not rare at all. It complicates, as I said, the immune compromisation that occurs in otherwise healthy patients of COVID-19 who have been treated chronically by steroids and monoclonal antibodies, especially the well-known Actemra. It is a life-threatening condition, you'll see why, and it extends from the paranasal sinuses. There is growth of fungi, and fungi here have a hyphal growth, and the septate variety of hyphae is not represented here. The hyphae of Mucoralis family are non-septated. The hyphal growth invades the arterioles, leading to endothelial damage, and this is consequenced by thrombosis, ending in endarteritis obliterans, infarction, and septic necrosis. And the inflammation would be of the active suppurative type, acute suppurative type. And if treated, it may shift into being chronic, and intracranial spread via the ophthalmic artery may occur. And in this condition, the whole mucormycosis is deadly in a matter of 2 weeks. The macroscopic picture of this disease is one of excessive necrosis with formation of black eschers and secondary suppuration. And microscopically speaking, the arteries, this is an arteriole, are occluded by hyphal growth of the fungi, and this is the black thing causing the endarteritis obliterans that ends in necrosis, as we said in the macroscopic picture. So hyphal growth, intravascular endarteritis obliterans, necrosis, and formation of eschers. Eschers are necrotic scars. And then we shift to Igg4 disease, which is a chronic, non-specific orbital inflammation. As I said, it was previously called or nominated orbital pseudotumor, orbital inflammatory disease, chronic orbital inflammatory disease. All names were of very indefinite nomenclature and were confusing. Now we have a consensus of opinion of calling this type of inflammation as Igg4 disease. We go back to the basic pathology lecture, and I remind you of the biologic characteristics of Igg4 disease. The biologic characteristics of the molecule of Igg4. Immunoglobulins, or Igs, are proteins that are secreted or released from the plasma cells in blood, and there are four types: IgG A, M, E, and C. And in particular, IgG is composed of bivalent, that means two sites for attachment of the antigen. Bi means two, valent, valency, a light chain and a heavy chain. Heavy chain is composed of two parts, that's why it's given A and B name. So it's F, A, and B, and the chain, the small chain, is FC, and this gives bivalent attachment site. The antigen may attach to these two ends of the two components. And the IgG has the characteristic of binding together and making a big molecules. These are protein molecules, as you all know. So Igg4 disease is a chronic inflammatory condition where the tissues are infiltrated with lymphocytes and Igg4 secreting plasma cells. The various degrees of fibrosis may occur due to the inflammatory process leading to scarring, but no necrosis. And usually marked response, there's a marked treatment response to oral steroids. Clinically speaking, there is an elevated serum level of IgG4 in particular. There is a massive cellular infiltration with subsequent fibrosis, and this leads to a tumor-like enlargement, and that is why it was previously called a pseudo-tumor. It looks like a tumor, but it is not malignancy. It's not even benign hyperplasia. So it's a tumor-like enlargement, but of inflammatory nature, and it is due to the infiltration by Igg4 secreting plasma cells and lymphocytes. This leads to orbital damage. Under the microscope, there is a dense lymphoplasmacytic infiltrate, as we said. And if you stain by immunoperoxidase staining, you will find the cells positive for this. And there is a storiform fibrosis under hematoxin and leucine. Storiform means like a cartwheel, like a wheel with radiant strays. You know, the wheel with a different concentric rays in the center. Looks like a cartwheel. So it is a storiform, means like a cartwheel, fibrosis under hematoxin and leucine, and under staining by immunoperoxidase, Igg4 staining, plasma cells are positive, and the lymphocytes are negative. So it is a non-granulomatous chronic inflammation with massive cellular infiltration with fibrosis and may show eosinophils as well. But the main cell is the immunoperoxidase positive plasma cells besides lymphocytes. In the body, this disease may affect many parts like the submandibular glands, the lacrimal glands, the thyroid, even sometimes the kidneys and the mediastinum, may lead to periaortitis or aortic aneurysms. But in the eye, it mainly affects the orbit, causing what we call pseudotumor, the previous name, and may affect the lacrimal gland, causing the ambiguous syndrome termed Mucous syndrome. And here's a graph showing how many parts of the body that might be affected by this syndrome with different manifestations. So Igg4 disease might be a systemic disease and might affect the orbit and lacrimal gland only. Presentations are different. It is a chronic condition, but sometimes may present acutely, as you can see, with orbital cellulitis of a subacute variety, may present by proptosis, may present by pushing the eye downwards or by inflammation in the area of the eyelids. This is an example of Mucous disease in the submandibular glands. And the CT scan shows a mass that respects the boundaries around it of uniform nature and pushing the globe. As you can see, the globe is squared here, but is not infiltrated, hence the name pseudo-tumor. Another example, and here it's affecting the orbital apex, and in this condition, different clinical manifestations due to compression occur in the pupil. Pupillary action is affected in the motility of the eye and above all in vision. Now we shift to another variety of chronic inflammations of the orbit, the specific type, which is sarcoidosis. And sarcoidosis is a chronic specific granulomatous inflammation, may occur in any soft tissue organ in the body. The possible etiology so far, we have theories, nothing sure. It might be an immune response to some sort of infection. It might be a sensitivity to an environmental factor, and probably there is a genetic factor. Why genetic factor? Because it's known to be commoner in African Americans. As well, it's more in females. The usual age of incidence is 20 to 40. It's very, very rare in young children. Throughout my life, I've seen it once in a child, and we were very reluctant to complete the diagnosis till we had the biopsy result. It is a non-caseating granuloma with multiple multinucleated giant cells. Why do we say non-caseating? Actually, the term has very small place in modern literature. This in the past was given to differentiate it from tuberculosis, where tuberculosis was common then and was characterized by caseating granuloma. By caseation, we mean the liquefaction of the tissues to resemble melted cheese. So a chronic granulomatous inflammation, non-caseating in nature with multiple multinucleated giant cells causing different manifestations in the lacrimal gland or in the lids. Sometimes it may present acutely and it responds very well to steroids, just like Igg4. You see steroids improve the condition markedly. Under the microscope, we have no caseation. We have multiple multinucleated giant cells. This is the giant cell with multinuclei and vacuolation in the center. Another multinucleated giant cell, multinucleated giant cell, but no caseation. Now we're finished with inflammations and we shift to the second part of the lecture, which is orbital cysts. And cysts in the orbit might be either of these 6 categories. The first is congenital, second is blood cysts, third is parasitic, fourth mucus, fifth dental and indigenous, and 6 is cysts of organs. I remind you here that mucus without O, M-U-C-U-S, is a noun, while M-U-C-O-U-S is an adjective. So mucus is the noun. Congenital cysts include dermoid, congenital cystic eyeball, microphthalmos with cyst, or cephalocele projecting into the orbit from the roof. Blood cysts include the 2 pathologically distinguished varieties. The first is hemorrhagic cysts, and the second is hemorrhage in a cyst. To know the difference in pathology, whatever cyst might get hemorrhage inside it, leading to hemorrhage in a cyst, like a dermoid or even a hemangioma, might get a hemorrhage inside it and become encysted. But hemorrhagic cyst pathologically is a different entity, where a hematoma accumulates in the orbit, and this hematoma, when accumulating, it compresses its center, which becomes with time necrosed and liquefied by blood enzymes with a pseudo capsule formed of the non-liquefied organizing hemorrhage. So a hemorrhagic cyst is purely blood that has changed pathologically over time by liquefaction of the center and the formation of the capsule or pseudocapsule around. This is different from hemorrhage in a cyst. So hemorrhagic cyst or hemorrhage in a cyst, both are different from one another, and this has a big impact on decision for management. Of course, we don't speak management here in pathology. And then we come to parasitic cysts, and the most well-known is the hydatid cyst, or the Cysticercus cellulosus cyst. Of course, hydatid cyst is caused by the scoliosis of the Echinococcus granulosus parasite. Mucous cyst is a cyst with a capsule full of muci. Its origin is not known so far. It's one of the rare cysts. Dental and indigenous cysts due to abnormalities during the formation of the branchial arches, embryologically speaking. And cysts of organs, like a cyst in the lacrimal gland called dacryops, or a cyst in the optic nerve called optic nerve cyst. We start by dermoid cysts, and dermoid cysts are differentiated into 2 types pathologically. Either sequestration dermoid or implantation dermoid. Let's start with implantation, which is the simpler variety. If, for example, one has a pin prick, if the pin pricks the skin, the pin may drive the epithelium of the epidermis into the dermis. And this here acts like an inciting agent for formation of a dermoid cyst. So the epithelium of the dermis becomes in the hypodermis, and in this case, it is a dermoid cyst. Sequestration is the embryological migration of the epidermis again into the hypodermis, and this occurs at the midline of the face, which we study in embryology. I just opened the camera to show you how the midline of the face goes. The midline of the face is not like this. This is wrong because the face is formed, embryologically speaking, of three processes. The two frontonasal processes and the mandibular process. So the frontonasal processes and the maxillary process. So the midline goes from the lateral side, below the eye, at the side of the nose, and in the middle at the philtrum of the lip. So sequestration dermoid cysts may occur at the lateral angle, at the medial angle, or at the upper lip. This is a very important pathogenesis to understand the site of sequestration dermoids. In children, it may occur at the lateral brow. It's usually smooth and palpable and mobile. It's firm with rubbery consistency and cystic in nature. In adults, superior and temporal, deeper in the orbit because it has got time to grow. It's not palpable nor mobile due to the deep growth and may displace the globe and adnexa, cause erosion of the bone and attach to dura through defects in the roof. So the difference between children and adults in presentation is that in children, it is still small, mobile, and smooth. But in adults, due to the time taken, sorry, I choked. Again, the difference between dermoid cysts in children and adults is that in children it's small, it is small, smooth, and mobile, but in adults it's more compressed, has taken time to grow, compressed the bone, may be extended into the orbit. Now, as a dermoid, and by the way, oid means like, it's a dermis-like cyst, so it is a dermoid cyst. It has got a lining of keratinized epithelium with dermal appendages like hair follicles and sebaceous glands. You know, the structure of the dermis is an epithelium with appendages, which are the hair follicles and sebaceous glands. Here is one at the lateral eyebrow, and here's after excision. As you can see, inside there are hairs and there is sebaceous glands. Another one, and under the microscope, this is a cut section in a hair, and this is a cut section in a sebaceous gland with lining, not covering, that is from the inside, lining of keratinized epithelium with dermal appendages, as we said. We're finished with dermal cysts, and now we come to orbital tumors. And orbital tumors are either choristoma, hamartoma, mesenchymal tumors, neural tumors, lacrimal tumors, or reticuloendothelial system tumors. Point of order here is that a tumor in pathology means a mass. And this mass might be a neoplastic mass or a non-neoplastic mass. That means not all tumors are neoplastic. By neoplastic, we mean the growth that might be either benign or malignant. So the term tumor to lay people immediately means cancer. But for us, a tumor is a mass. And this mass might be a choristoma or hamartoma, we know the difference now, or mesenchymal in origin from the mesoderm, embryologically speaking, might be from the neural tissues, might be from the lacrimal gland, or from the reticuloendothelial system. And by choristoma, we mean anomalous tissue formation, not normally present in this location, and hamartoma, anomalous tissue formation that are normally present. So a choristoma or a hamartoma is anomalous tissue formation. What does this mean? This means that the tissues in this location became disorganized, unlike the usual thing. For example, a blood vessel is known to be formed of a tunica adventitia, a tunica media, and a tunica intima, formed of endothelium. Once these tissues are haphazardly arranged, we find things like angioblasts, cells, and blood outside or inside spaces formed by these angioblasts, not necessarily blood vessels in the way that we are accustomed to see. If anomalous tissue formation is not belonging to this locality, we call it choristoma. But if it is belonging to this locality, we call it a hamartoma. And hamartomas are like hemangioma, lymphangioma, telangiectasia, or arteriovenous malformation, mostly vascular, because every area in the body is vascular. But if this anomalous tissue formation is away from its location, like a dermoid cyst or an epidermoid cyst, so the dermis became in another location, it migrated into the hypodermis, so it gave the choristoma, which is an anomalous tissue formation, as you said, as we've seen. The hair follicles and the sebaceous glands are inside, not growing out. And like teratomas actually are tumors or masses formed of the three generative or germinative tissue layers, that is ectoderm, mesoderm, and endoderm. Or ectopic lacrimal gland, like a lacrimal gland occurring behind the globe in the orbit, for example. So now we know the difference between choristoma and hamartoma, and we are going to describe in more detail. Now the mesenchyme. The mesoderm gives rise to the vessels, the muscles, the cartilage, and bone. So all these tissues might give origin to tumors that are mesenchymal tumors. Examples are hemangioperiscytoma or hemangiosarcoma, benign and malignant, or Kaposi sarcoma, leiomyoma and leiomyosarcoma, tumors from the smooth muscles, or rhabdomyoma and rhabdomyosarcoma, tumors from skeletal striated muscles, chondroma or chondrosarcoma from the cartilage, osteoma or osteosarcoma from the bone. Of course, you know that sarcoma is the malignancy of tissues originating from the mesoderm, and carcinoma is malignancy of tissues originating from the ectoderm. Now, neural tumors, because the neural tissue is a very specific embryological type of tissues, that is the neuroectoderm that was driven from the ectoderm, but it's not ectoderm, it's a neural ectoderm, like neurofibroma and neurolymphoma. Lacrimal tumors like lacrimal duct cysts, benign mixed lacrimal gland, and malignant mixed lacrimal gland. Reticuloendothelial system, that is the lympho and blood tissue that is coming from the bone marrow. Lymphoma, leukemia, multiple myeloma, and gammopathies. So choristoma is anomalous tissue formation not normally present in the location. We are revising or repeating dermoid and the epidermoid, teratoma and ectopic lacrimal gland. Hamartoma is anomalous tissue formation normally present in the location, like hemangioma, lymphedema, telangiectasia, and arteriovenous malformation. By teratoma, as I said, it's misdirected or ectopic germ cells that can result in massive proptosis. Is very rare. All the three germ cell layers are represented, resulting in compression, destruction, but with no infiltration. It has got a mass effect only. And this is an example of a big teratoma showing a tooth or tissue that resembles a tooth. And it is a very big but benign teratoma. Malignant teratomas are known to occur in the gonads, in the testis and the ovary. Now, cavernous hemangioma, which is a hamartoma, which means anomalous tissue formation that is usually present in the location. It is the commonest benign neoplasm of the orbit in adults. So if you are asked, what is the commonest cause of proptosis in children, it is not tumors, it is orbital cellulitis. What is the commonest benign neoplasm of the orbits? This is actually wrong. It should be the commonest mass of the orbit in adults. It's not a neoplasm. So hemangioma is the commonest benign mass in the orbit in adults. Occurs in middle-aged individuals, like more in females, causing proptosis and compression, and the size usually increases during pregnancy. It's well circumscribed within the muscle cone, has a very well delineated capsulis encapsulated, has large venous-like spaces, venous because no muscle around, not arterial, with septa of various thickness. And if you come to removing it, it is like the nucleus of a date. It's just like a nucleus of a date. Please make sure to mute all your mics. You're all muted. Thank you. So, hemangioma histologically is well encapsulated, very well delineated from the surrounding tissues, like a nucleus of a date. I hope you all had breakfast. You're not hungry. This date looks very delicious, I know. Now, the compression of a hemangioma on the globe causes a compression of the compressible part of the globe, and the sclera has a very elastic recoil. So once compressed, it shows no changes, but the choroid is the part that is not compressible, and once compressed, because it's filled with blood, it causes a sort of what we call it, like please, like raised areas and depressed areas, and we will see how. You see here, these lines are the folds in the choroid because of the compression. This is a raised area and this is a depressed area. You see, again, a raised area and a depressed area. The raised area is called the crest, and a depressed area is called a trough. Crest and trough. Trough in Arabic is khandaq. Crest is like, I wouldn't say Jabal, I would say Hadaba, for example. So we have here crests and troughs. And this is another example, very evident of, again, crests and troughs. And we will see why the crests are light and the troughs are dark. Now, this is the retina. The sclera is compressible. The choroid is full of blood. And this is the broad membrane with the retinal pigment epithelium above and the retina to the inside. When compression occurs, the raised area has the retinal pigment epithelium more dispersed. And this is the part that has got the pigment. And the troughs, which are the depressed area, has the retinal pigment epithelium more concentrated, more crowded. So in this way, a trough would look darker and the crest would look lighter. This is a trough, lighter, and this is a crest, darker. Again, the cause is crowding or dispersion of the retinal pigment epithelium. Now, does this affect vision? The answer is yes, sometimes, not always. It may affect vision. And the way of affection of vision is that, that the cones inside the fovea are in direct contact with the retinal pigment epithelium and depending on the retinal pigment epithelium for nourishment. And if the cone is separated from the underlying retinal pigment epithelium, this results in loss of central vision. But if the crest does not pass through the fovea, central vision would be preserved. Back again, the hemangioma is a smooth, well-circumscribed mass here located within the muscle cone. This is an example of a gentleman with hemangioma of the capillary, of the cavernous type, cavernous hemangioma. It's causing proptosis. And here's from the side, and on the CT, it looks like a very big mass, as big as the globe. Here it is. And on excising it, it comes out like the nucleus of Eddy. It's very easy to take out, but probably more difficult to approach. And we've described this in surgery of the orbit, how to approach it, especially when it is in the muscle cone, inside the muscle cone. Under the microscope, as we said, it's encapsulated with connective tissue capsule with large spaces with angioblasts around, but no muscle. So that's why they are venous-like spaces. Venous-like, they are not actual veins, not passing from a small venule into a bigger venule and then draining into a big vein. No, just spaces. And that is why it's disorganized, and that's why we call it a hamartoma, or we classify it as a hamartoma, with septa in between, and these septa are of various thickness. Sometimes the space is big, sometimes the space is small, and in this way, the tumor might be a bit compressible. Again, encapsulated large venous spaces with septa of different or various thickness. Cavernous hemangioma is a disease of adults. Capillary hemagioma is a disease of children. It is the commonest primary benign mass in children. And it enlarges over the first year of life, usually involving the eyelids. It's called the strawberry nevus because it's red elevated and it blanches on pressure. If you press on it, it becomes white and involves the medial upper eyelid. Looks like a strawberry. So it looks like a strawberry, mostly resolves spontaneously. And if it is large and it's causing ptosis of the eyelid, this may lead to amblyopia and hence maybe strabismus squint as well. It's different from the cavernous hemangioma in being unencapsulated. It's not capsulated. And the spaces are capillary sized, not venous-like. They are smaller with high cellular stroma. This is mass in the eyelid. It's a capillary hemangioma, making the upper lid look like an S shape, an S on its side. This is an S. If I draw it in a bigger scale, it would be like an S on its side. And this is the strawberry nevus. This looks like a strawberry, and all this is spontaneously disappearing, but it may leave ill effects if it covers the pupil, may lead to amblyopia if it is left in place. like a strawberry. And here the treatment, although this is pathology, but the treatment depends on the pathology. It was accidentally discovered that beta blockers treat this condition early. And the actual reason behind is that the growth of angioblasts is a beta effect, and beta blockers stop it. As you can see, the difference is unencapsulated. There are no capsules. It's capillary-sized spaces. The spaces are smaller with highly cellular stroma. The stroma in the cavernous hemangioma is big, of various sizes, but not infiltrated by cells as much as here. Now, another hamartoma, which is lymphangioma. The origin is lymphangioblasts, not hemangioblasts, the cells that form the walls of the lymphatics. It occurs in the first decade of life. It's uncommon. Of course, the spaces are filled with serum, not with blood, lined by endothelial cells. But the mass itself is vascular. That means the septa in between are infiltrated by vessels. It's unencapsulated like a capillary hemangioma, not like a cavernous one, maybe located in the deep orbit or in the eyelids. Sometimes it's small, and when it is exposed to trauma, it gets hemorrhage inside. So this is, as we said before, hemorrhage in a cyst, and the hemorrhage becomes compressed and liquefied, giving the known chocolate cyst. It's all food this morning: chocolate, dates, strawberry, and we have cheese, and we have salmon later on. It's a big menu today. Younger children, if it occurs in the eyelid, as we said, just like capillary hemangioma, it may lead to amblyopia and or strabismus. Here it is a big mass filled with serum. Mass filled with serum, no hemorrhage yet. The endothelium lined spaces, known, no pericytes. If you search for the blood vessels or the blood spaces in hemangioma, whether capillary or cavernous, you'll find pericytes, which is a character of all blood vessels, not lymphatic vessels. No smooth muscles, scattered follicles of lymphoid tissue and interstitial capillaries. As you can see, big spaces lined with endothelium, vascular interconnective tissue septa, no pericytes, no muscles, and lymphocytes scattered everywhere, and interstitial capillaries, as I said. Now we come to another hamartoma, which is hemangiopericytoma. This is an uncommon condition that occurs at the age of 40 to 50, with compression and restriction, well defined on a CT, bluish at the time of surgery, may undergo malignant degeneration. We describe it macroscopically, but I don't believe a surgeon can diagnose it with the naked eye. You have to take it out and usually missed for a hemangioma. And when examined under the microscope, you will be confronted with the diagnosis of a hemangiopericytoma. Hemangiopericytoma, again, it is very uncommon, causing compression, as we will see. Under the microscope, it's encapsulated, hypervascular, hypercellular, with the pericytes, which are the tissue of origin, very prominent. And this leads to the configuration of vessels, which is like a stag horn. A stag is the wild animal, sometimes called a deer, but a deer with a stag with a big horn that is branched. And here is the horn that is branched, staghorn vessels, encapsulated, hypervascular, as you can see, hypercellular with plump pericytes and a staghorn configuration of the vessels. Where is the word vessels? Of vessels. There is a word vessels, but it is in, it's behind this tag. Here is vessels. Some opportunity to take some rest. So it is encapsulated hypervascular hypercellular with plump pericytes and vessels resembling a stag hole. Again, vessels resembling a stag hole. Very vascular, very heavily infiltrated by cells. Now, Kaposi sarcoma. And Kaposi sarcoma was a very extremely rare tumor, but in the 80s of the previous century, it started to gain attention because it occurred in 25% of AIDS patients. AIDS, you know, AIDS. 90% of them were males. It is a skin. It occurs in the skin, in the mucous membranes, and in the viscera. So it may occur in the skin of the eyelids. Capillary clusters with stroma of malignant spindle cells may admix with lymphocytes, hence the nerve malignant granulation tissue. So the malignant cells are the stroma, the spindle cells, with admixture with lymphocytes. Look bluish, may occur in the eyelid, on the trunk, on the arms, on the face, may cause hemorrhage on the conjunctiva. Many foci of capillary clusters with stroma of malignant spindle cells with admixture of lymphocytes. Now, an important tumor, which is rhabdomyosarcoma, and is the commonest primary malignancy of orbit in children. It is the commonest primary malignant mass in the orbit in children. It's very aggressive, rapidly causing proptosis, rapidly growing, and it mimics cellulitis. It presents like an orbital cellulitis. Because of the rapid growth, it may resemble cellulitis. On a CT, it's a solid mass arising from around an extraocular muscle. Histologically speaking, it's composed of actually 3 types. The third is mixed, and the embryonal type and the alveolar type. The embryonal type has the rhabdomyoblasts arranged into fascicles alternating with myxoid areas, and the alveolar type has alveoli. The rhabdomyoblasts are discohesively swimming in the centers of the alveoli, we'll see now, with delicate fibrovascular septa, and this is more malignant. Here is proptosis in a child around 5 years, and this is the example here. So proptosis, or a mass in the eyelid. Here, a sort of acute cellulitis. The embryonal type is composed of fascicles, that means bundles of rhabdomyoblasts of malignant nature, alternating with myxoid tissue. So this is the myxoid tissue taking the enzyme stain, and these are the fascicles of malignant myoblasts or rhabdomyoblasts. The alveolar type is composed of alveoli with thin connective tissue septa, with delicate fibrovascular septa, This is more malignant because the tissues have a lost polarity, are less polar, more malignant. Now, neuroblastoma, it's a malignant neoplasm of embryonic tissue that metastasizes to the orbit. Common childhood malignancy, presents with ecchymotic eyelids. Of course, clinically speaking, you never differentiate it from a rhabdomyoblast until you make a CT scan. I'm sorry, I don't know why this is repeated here. Excuse me. A neuroblastoma is, excuse me, I read neurofibroma as neuroblastoma, I'm sorry. So a neuroblastoma is a tumor that originates from the embryonic neural tissue that metastasizes to the orbit. It's common in childhood malignancy and presents with ecchymotic eyelids. Neurofibroma, the other one was neuroblastoma from neuroblasts. The neurofibroma, this is a common or classic teaching issue. It is caused by proliferation of Schwann cells, which are the wrapping cells of the peripheral nerves that are responsible for proliferation of peripheral nerves when cut. May occur throughout the body, anywhere where nerves are occurring. It's autosomal dominant linked to chromosome number 17. Optic nerve gliomas are common association and has two types, neurofibroma 1 and neurofibroma 2. So a neurofibroma is a proliferating Schwann cell that may occur through the body, autosomal dominant linked to number 17. Neurofibroma 1 is commoner. 1 in every 3,000 live births, while 2 is 1 in million. It is characterized by cutaneous café au lait patches. Café au lait means coffee with milk in French, and this is the known color, with Lish iris nodules. Lish is a name of the ophthalmologist who described these, with thickened choroid hamartomatous process. It is, as long as it's a proliferation of Schwann cells, so it is an abnormality that is usually of tissues that are usually present in the location. So it's a hamartoma. So a neurofibroma is a hamartoma by definition, may be associated with orbital bony malformation like absence of the wings of the sphenoid, and the wings of sphenoid form many parts of the walls of the orbit, as we know from the anatomy, and this leads to a continuous relationship between the cranial cavity and the orbit, and leads to pulsating proptosis. It feels like a bag of worms, causing proptosis restriction and compression. A bag of worms for fishermen is like the bait that they use for fishing. الطعم بتاع الصيد, bag of worms. So a neurofibromatosis type 1, 1 in 3,000, café au lait skin patches, Lish iris nodules, and feels like a bag of worms with bony abnormalities. Neurofibroma type 2 is less common, 1 in a million, less prominent skin lesions associated with acoustic neuroma, which is a benign tumor of the 8th cranial nerve, as well as the other features of neurofibroma 1. This is neurofibromatosis with a café au lait patch on the abdomen, and the multiple potato-like masses due to proliferation of the Schwann cells, and the anterior surface iris nodules called Lish. Masses on the back surface or pupillary edge are called Busarca. And the interesting thing is that in this patient, there is an incision of laparotomy, meaning there is a mass that was removed surgically before. Now, proliferation of Schwann cells may lead to this picture of facial deterioration. And we finish neurofibroma and come to mold lymphoma. Mold lymphoma. The word mold, M-A-L-T, not all capital, is a plant, a sha'ir. But here mold, capital A, capital M, capital E, capital L, capital T, stands for mucosa associated lymphoid tissue. Why we say mucosa associated lymphoid tissue? Because in the orbit there are no lymphatics. Remember, in the orbit there are no lymphatics. And in the eye there are no lymphatics. There are lymphatics in the conjunctiva, and there is evidence of a very small area in the meninges of the optic nerve at the orbital apex that might have lymphatics. The cell type of origin here is B cells, marginal zone, extranodal B cell lymphoma. It is a tissue that is like lymphatic tissue that is associated with the mucosa that may lead to the formation of lymphoma. And lymphoma here causes proptosis, lacrimal gland enlargement, and visual loss. And in the conjunctiva, it has the particular color of a salmon. Salmon color, rubbery, smooth, and not benign. And on biopsy, it shows monotonous sheets of small blue cells. To my mind, I don't like the description of salmon, me myself, because salmon, or actually the right pronunciation is salmon. If I say salmon, most of us won't understand the meaning of the word. This shows you how very unpopular for us salmon is, but the thing that's near to our minds is small flesh of veal. لما نطلق عليه اللحم البتلو. And as you can see, the mass here looks really like لحم بتلو, not like salmon. So whether you call it salmon-like or betello-like or whatever, that's agreed as long as you suspect this mass of ill-defined edges and very particular pink color as lymphoma. If you suspect lymphoma here, you may save the life of this patient. It looks like a putty-like molding on a CT scan, putty-like molding of the mass to the pre-existing orbital structures without bony changes. زي الطين أو الصلصال. When you put it in the spaces, it fills the spaces, protecting everything around it. No infiltration, no pushing. Remember, sarcoidosis, it pushed the globe and caused the squaring of the edges, although there is no infiltration. But here it's soft to the extent that the globe shape is very well respected. Under the microscope, a biopsy would show monotonous sheets of small blue cells. What's the meaning of monotonous? Means there is no arrangement whatsoever. No cartwheel, no fascicles, no nothing. Just monotonous sheets of small blue cells. And this is the high power view, and small blue cells with big nuclei and scanty cytoplasm around, which is the well-known character of lymphocytes. Finished with lymphoma, we come to pleomorphic adenoma, and by pleomorphic adenoma of the lacrimal gland in particular, we mean the mixed lacrimal gland tumor. It is benign in nature, painless, slowly growing, occurs in adults. It's the commonest lacrimal gland tumor, firm with lobular masses, and may cause proptosis. And proptosis, anatomically speaking, would be medial and inferior in this case here. It has a potential for malignant degeneration. Again, it's a benign, painless, slowly growing mass of the lacrimal gland, firm with lobular texture with medial and inferior proptosis. Under the microscope, it's variable. That's why we call it pleomorphic. Maybe benign epithelial proliferation, double cell-lined lumens filled with mucus, intermixed with myxoid stroma, populated sparsely by spindle-shaped cells. Double-lined lumens, like this, 2 cells, filled with mucus without O, intermixed with myxoid tissue stroma, taking the Eosin red or pink stain, populated sparsely by spindle-shaped cells. Sometimes, by the way, there are no lobules, just spaces. It's not like a gland, it's like a duct filled with mucus, intermixed with myxoid stroma. Sometimes the stroma is much than the spaces or lumens, much more existent. Sometimes the reverse, that's why we call it mixed or pleomorphic. As you can see, here is excessive myxoid tissue and here is less myxoid tissue. Double-lined spaces with spindle-shaped cells in between. Now the adenoid cystic carcinoma, again, of the lacrimal gland, it's malignant, unencapsulated, eroding adjacent bone, has perineural invasion causing pain. And it has the Swiss cheese cribriform pattern. Swiss cheese is any cheese that has air spaces inside. You'll see why here. Now the adenoid cystic carcinoma originates from the acini, but the benign mixed pleomorphic originates from the ducts. That's why here the acini are multi-layered, but the other one, the pleomorphic adenoma, is 2-layered. So this is the cribriform appearance of the Swiss cheese or the adenoid cystic carcinoma. Now the last subject in this, I know, heavy lecture is juvenile xanthogranuloma. And this is a form of histiocytosis classified as non-Langerhans cell histiocytosis, more specifically type 2. What is histiocytosis? It's a group of rare diseases with excessive tissue macrophages, which are histiocytes. You remember from the lecture on basic pathology. Confusingly, it's used to refer to some other diseases, but histiocytosis is a well-known pathological term that is very confusing to pathologists. Rare diseases with excessive histiocytosis. The WHO classified histiocytosis in 1999 into type 1, type 2, type 3, and type 4. Benign masses with vascular disorder occurring in infants and young children, singly or in props, may regress spontaneously, may cause spontaneous hyphema or secondary glaucoma. So they are benign masses. Again, we are speaking about juvenile xanthogranuloma. Juvenile xanthogranuloma. It's a benign type of histiocytosis called non-Langerhans cell histiocytosis. Masses of benign nature, vascular nature in infants and young children, either one or multiple, may regress spontaneously, but known for causing hyphema and secondary glaucoma. Now, under the microscope, it shows diffuse granulomatous inflammation with many histiocytes and two-tone giant cells. This is juvenile xanthogranuloma. Xantho means yellow. Diffuse granulomatous inflammation with many histiocytes with two-tone giant cells, with the multinucleated giant cells with the nuclei arranged in a horseshoe pattern. Now we come to the rarer variety of xanthogranuloma, which is adult xanthogranuloma, non-Langerhans histiocytic, again, disorder. No sex preference, appears on average at 50 years of age. Its diagnosis depends on the appearance of an inflammatory orbital disease with periocular xanthoma that is yellowing around, plus or minus systemic features. Under the microscope, the histiocytes are foamy, and again, it shows two-tone giant cells with varying degrees of fibrosis and necrosis with lymphocytes. There are 4 types of histiocytosis, adult xanthogranuloma: the adult onset with xanthogranuloma, the necrobiotic variety, and the Erdheim-Chester disease. The details are not very important to you, but once you are encountered with a case, you have to come back to this and to read it. The adult onset is isolated, occurs in the lacrimal gland and extraocular muscles, no systemic involvement, as you can see, there are yellowing around. Don't mix it with xanthelasma. Although clinically speaking, you may confuse it with xanthelasma until you take it under the microscope. You find one with a multiple foam cells and this one with multiple histiocytes. This one is a more pronounced disease with asthma and lymphadenopathy, high IgG level, very big masses, and with asthma, and the necrobiotic type, which is accompanied by necrosis of the skin with multiple myeloma and less systemic involvement. And the ultimatum of the series is Erdheim-Chester disease. It's most devastating, dense progressive fibrosclerosis involving the orbit and internal organs, mediastinum, and so on, and it causes death in almost 70% of the population. Thank you very much, and I am ready to receive your questions, please.
Doctor, can you repeat the mold syndrome?
دكتورة نانسي repeat ايه يا فندم؟ repeat ايه؟ ما سمعتش حضرتك. دكتورة نانسي هي تقريبا كتبت mold. mold. Mold lymphoma. We are speaking about lymphoma, and it is a lymphoma, but there is no lymphatics in the orbit. That is why we have to know the origin. The origin is mucosa-associated lymphoid tissue that associates the mucosa, and the mucosa here is the conjunctiva. Okay. So it is simply a lymphoma that originates from the mucosa-associated lymphoid tissue. I am trying to find it for you. It under macroscopically speaking, it looks like, as we said, salmon pink mass, and under the microscope, it looks like sheets. Here we are. Sheets, monotonous of lymphocytes. Mucosa-associated lymphoid tissue, origin from the B cells in the marginal zone. The lymph nodes in the body, we have lymph nodes, we have known lymph nodes here. Lymph nodes in the body are described histologically speaking as having a central zone and a marginal zone. And in the marginal zone, there are B cells and T cells. And the mold lymphoma originates from the B cells in the marginal zone. It's extranodal, there are no lymph nodes. It is a marginal zone B cell lymphoma, marginal extranodal B cell lymphoma. This is the classification. Proptosis, salmon color, smooth, rubbery. وقلنا قصة قصة البيتيلو mass. And once you find a mass like this, you should suspect lymphoma. Thank you.